Okay, any questions before we get started on this next bit? So as after that conk in the head, we're going to be monitoring brain hemodynamics and metabolism, again, because we're worried about that reperfusion injury. We're worried about changes to hemodynamics altering oxygenation, blood pressure within the brain. If we change the brain's metabolism, that could result in fever, seizures, agitation, and pain. Again, you have a blood-brain barrier, blood gets in there, it's going to be a very big problem. So again, TBI, we're going to measure traumatic brain injuries with the Glasgow Coma Scale, and that's going to be a measure of level of consciousness. Some other definitions related to TBI is a few things can happen to your brain. You're going to have the direct injury, right? So you get conked on the head, there's the direct injury, smacked the frontal lobe is injured. That's a focal injury. There's also a way to get a polar injury, which means you get smacked on the head, and then the back of your head smacked into the back of your skull, or the back of your brain smacked into the back of your skull. So like whiplash, for example. Or just you get if you had a hammer and it goes like this, your brain's going to slosh over and hit the back. Just like that, and it's going to fall apart. Literally fall apart like that. So we would call that a polar injury. There's going to be the initial insult, and then it's going to smack against the opposite side. It would work side to side as well. You smack this side, your brain sloshes over and hits the other side. And I'm not saying that there's another like hammer over here. I mean literally the physical brain smashing into the skull at that point. So that's polar. It's also called coup contre coup, C-O-U-P, coup contre coup. Yeah.
So would polar be like football players like smashing helmets, they smash
Sure.
helmets, and then it flips back?
Yeah, absolutely. So football's a great example for TBIs
Oh my god.
all throughout. Yeah, no, it's like what this is all about. It's just you should be imagining football players and car accidents and ski accidents and I mean anything, motorcycle accidents, every accident, falling off a ladder, etc. Okay, and then there's also finally a diffuse injury where you shake that brain around in the skull and we can injure the entire thing. And that's going to be a diffuse injury.
How what kind of injury?
Like let's say a car went end over end or shaken baby syndrome. There you go. Boom. Like how that chorus happened. Yeah. Mm-hmm. It depends on the severity, right? So you could have the focal, and then if there was any sloshing, it could have been the polar, and if there was even more, it could have been diffuse. Yeah.
So you can have more than one of these.
Oh yeah, yeah. I mean, you would start here for like minor, and then you would work your. I don't have my arrows on. Sorry. You start up here for minor, and then you would work your way up, basically. Yeah. One thing, and again, we've already talked about a few things that can happen, space-occupying lesions and things like that. Intracranial hematomas are a potential outcome of TBI, which means there's been a bleed, and they're just going to be named on the location of the bleed, and there's going to be some slightly different rules of thumb for clinical outcome depending on the location and severity of that bleed. Now, what I'm teaching you are like general rules of thumb. And I know you've worked at Craig, so you know that like one person can manifest this way, one person can manifest that way. It's not a perfect thing. It's just, again, it's the physiology of what technically it's most likely to be for these different hematomas. So when we say epidural, we mean superficial to the dura mater. When we say subdural, we mean deep to the dura mater. And when we say subarachnoid, we mean deep to the arachnoid mater. Deeper and deeper. And these are going to look a little bit different on imaging. They're going to have different clinical outcomes as a rule of thumb. So epidural, so this red line here represents the dura mater. You can see that a bleed into this space is going to compress. It's going to peel the dura mater away from the bony cranium as it takes up space and compresses the brain. And whereas a subdural, it's still going to be superficial to the arachnoid membrane. So that sort of orangey line is going to be arachnoid, I believe. So we're going to have your, maybe not, that's subarachnoid. That's poorly illustrated. Anyway, a subdural hematoma is going to be deep to the dura mater, but superficial to the arachnoid. It still hasn't gone past the blood-brain barrier, which is the good news there. But it's going to be closer to the surface of the brain. That arachnoid is a thin membrane. It's not a thick membrane like the dura mater is. You have a question?
I was gonna say, with these, could these also raise ICP, right? Because the blood's getting too big. So when is it like a certain number, certain just situation when they do like a craniectomy, like to let it go?
This would be an excellent time to do a craniectomy.
Okay.
Yes. These two would be an excellent time to do a craniectomy.
But you wouldn't do a craniectomy for subarachnoid, right?
It's going to be a little more complicated for subarachnoid. I looked more carefully at the visuals. That white line is arachnoid, whereas the orange line I think is supposed to be pia. So let's re-clarify that. So we're superficial to arachnoid. This is subarachnoid. In a subarachnoid hemorrhage, you have violated the blood-brain barrier. So the clinical manifestations are actually going to be just as much related to inflammation in the brain, having those blood cells and inflammatory cytokines and products within the brain where they are really not supposed to be. So we will go into more detail about this. We did coup contre coup, we did diffuse, concussion. It's kind of weirdly organized. Let's go to intracranial hematomas, then let's go back to slide 23 after I've described these. So intracranial hematomas, epidural. On clinical imaging, it's going to look a little bit like this. Notice that there's a smooth line. You cannot identify gyri and sulci on this image. What you can see is that we're going to have a midline shift. So you have that peak of the skull there, and then there's the base of the skull there, and there you can draw an imaginary line, and you can see that the falx cerebri is shifted from that midline right there. So you can see this is pushing in this direction. Oh yeah, that's a big one. So typically you would expect this to be an arterial injury, and arterial injuries are going to bleed a lot faster than venous injuries. And again, this is a rule of thumb. It's not going to be perfect. In fact, we're going to watch a surgical video of a subdural hematoma that is arterial in nature, even though I'm about to tell you that this is more likely to be veins. So I'm going to show you a video that contradicts our subdural hematoma video or statement. So epidural hematoma, more likely to be arterial, more likely to be a rapid onset. That's what we expect for this. So this is conch on the head, hit the floor within minutes. This will be fast, so you definitely want a CT for that one. And we can do surgery, we can open up that cranium, we can physically remove, we can do something about that broken blood vessel. Subdural, typically the bridging veins, like I said, the surgical video we're going to watch is arterial, and you'll be able to tell it's arterial because it's going to be going and spraying out really high pressure. Yeah. So this is the one where like maybe grandma falls over and she gets up and she says, "I'm fine, dearie," and then like a day or two later she's in an emergency situation, and like suddenly her LOCs go down 24 hours later. Yeah, what's up?
Is this kind of like, I think she had aneurysm, but Liam Neeson's wife, how she said to me, I was like, I'm okay, I'm just kind of dizzy and went out.
Possibly. It depends. I don't know the full story of Liam Neeson's person. Okay. So again, that is still going to increase ICP. On the imaging, notice now you can see some gyri and sulci. See how it's kind of wavy in comparison to the epidural hematoma that's really flat? You can see the sort of shape of the brain the way it's supposed to be shaped. So that tells you subdural. I think that's really cool. You're not really responsible for learning about the radiology, but I think it's cool to know. Okay. And then subarachnoid, what you're going to see is you're not going to have that really obvious change. What you're looking for is those sort of inflammatory color changes. The issue here, I'm going to ask you for time scale on your worksheet today. It's going to be really variable. The issues related to subarachnoid, like I mentioned earlier, are about that inflammatory. You're going to have meningeal irritation. There's going to be headache, vasospasm, ischemia. The bread is spreading through the CSF and irritating the cells of the brain because you have a blood-brain barrier. Those cells are not supposed to be there. Those substances are not supposed to be there. It's literally irritating. So the onset of time is going to be a little bit variable. It's going to be a little bit different. It's going to appear very differently. Yeah, what's up? If it's arterial.
For the subdural?
Oh, for the subdural.
It says chronic prone to rebleeding.
I'm not entirely sure. I don't have a good answer for you right now. We can look that up though. Come back to it. Could be because this is more the grandma thing where she probably has problems with her veins anyway, but I'm just suspecting that. I'm not entirely sure. Okay, so let's go back to concussion. So a concussion by definition is a mild TBI. It's a very common injury, especially in the military or in our football players, athletes. So there will be a change in LOC, but it should be by definition less than 30 minutes. And on CT, there should be no evidence of brain damage. We shouldn't see a hematoma. If you've got a hematoma, you've got a hematoma, and that's more serious. It's basically a brain bruise. Yeah, it should heal. This one should heal. Now, we do have our newer evidence of accumulation of TBIs in football players. And I can actually, let's find that picture. Sometimes it takes me a minute to find. I'll pause for a second. So what you're looking at here is literal physical brain slices of football players. So you should expect the brain tissue to look a little bit more like that. But in people with a history of TBI, people who played football, what you have is accumulation of, I think it's a tau protein. So it's a metabolic waste that like sort of tangles physically and takes up space in the brain. So we are starting to call that chronic traumatic encephalitis, CTE is our name for that now. And yeah, now that we have enough football players who are willing to let this test on their brain, we're starting to see the evidence of this, that playing football is very, very dangerous and does cause irreversible brain damage. Getting in a car crash every single time you collide sounds about right to me. Now again, there's our initial injury, and then there's our secondary injury, our body's response to the initial injury. You can have ischemia, you can have hypoxic events, you can have edema, you have increased ICP. Those blood vessels, they can rebleed, they can go into spasm, and spasm is plenty enough. As you know from the heart, we can go into spasm and cut off blood flow to the heart, we can go into spasm and cut off blood flow to the brain. And we worry about that cascade. We worry about reintroduction of oxygen. We worry about introduction of immune cells. It's going to, in some ways, cause more damage than just hitting your head. Okay, TIAs, transient ischemic attacks. It means there was an ischemic event that resolved on its own. Sudden onset of neurologic dysfunction. There's probably cardiovascular disease in this person. It's probably something we can detect as a cardiovascular issue. Stroke is cardiovascular disease that does result in an infarct in the brain. There's going to be a couple of different kinds of stroke. There's ischemic stroke and there's hemorrhagic stroke, right? We've kind of already addressed some of the parts of a hemorrhagic stroke. A hemorrhagic stroke is going to be a lot like a subarachnoid hemorrhage, or in a way it is a subarachnoid hemorrhage. Let me see. So more commonly, the form of the stroke is going to be ischemic. You had a blood clot, it traveled to your brain, and it blocked some blood vessels there. Because that part of your brain became ischemic and then necrotic, and it died. Patch of your brain died. Your brain, those neurons cannot regenerate. They can't. Yep. That's a really common story, to go to the chiropractor and have a blood clot travel to your brain. It is really scary. Oh. So for the recording, that was a student in the class has had a 24-year-old patient with an ischemic stroke as a result of popping their neck. Sounds about right. Be gentle with your neck. Yeah. Those vertebral arteries, we're not joking around with those vertebral arteries. They're fragile. They're in your transverse foramina. You have a limited range of motion. Anything beyond this is hyperextension of your neck. Don't hyperextend your neck. When in yoga, if they tell you to like look up to the sky, just don't. Negative. Yeah. It could be because the vasculature is changing its blood supply to your brain when you do that. So that might be why. You should stop doing that. So more likely it's because a clot broke off and went to the brain, but less likely that we broke the blood vessels and it's hemorrhagic. Females are more affected than males, and the risk factors are the exact same risk factors for atherosclerotic and vascular disease. If you've got hypertension, if you've got diabetes mellitus, hyperlipidemia, smoking, advanced age, or family history. So get your cardiovascular stuff worked out, and then you're less likely to develop a neurological condition. So ischemic stroke, sudden occlusion of a cerebral artery. This is why you learned the cerebral vasculature, the circle of Willis. If anybody's curious about that cerebral vasculature, we can certainly review that. Aside from atherosclerotic plaque, it could also be a result of a coagulopathy. People with clotting disorders are also more likely to develop ischemic strokes. And it could be secondary to a sudden onset of, like, let's say a dysrhythmia. Or it doesn't even need to be sudden onset, but if somebody has a dysrhythmia, like an atrial fibrillation, that does mean they're more likely to throw a clot. Your symptoms, your signs and symptoms for stroke are going to be entirely based on where that stroke happened. So this is why back in our neuroanatomy unit, back in AMP1, we spent so much time on this lobe does this lobe does that, this part does this part does that. Because the distribution of that cerebral vasculature and which one got impacted is going to determine the clinical manifestations. Yeah, is it going to be verbal? Is it going to be auditory? Is it going to be motor? Is it going to be sensory? Is it going to be visual? Is it going to be taste? Is it going to be facial recognition, music recognition? Those, absolutely, it can. It's most likely to follow a pattern of being on the same side, on one side rather than the other, unless they're having really bad problems and multiple blood clots all over. What's that? On the ATI? Oh yeah, of course, absolutely. Do you want to look at the cerebral vasculature real quick? Not to memorize, but just to get some insight into the distribution of those blood vessels and what they serve? Okay. So here's the circle of Willis. Here's the internal carotid artery. Here is your, let's see, posterior communicating artery to your vertebral arteries, cerebellar arteries. Okay, basilar artery. This goes together into basilar and then back into vertebral. Okay, it looks about like this. You're going to have an anterior cerebral artery, a lateral cerebral artery, and a posterior cerebral artery coming off of the circle of Willis. The anterior cerebral artery is going to fuel the midline portion of your frontal lobe, and so like midline structure and medial structures and frontal structures. So it's doing like this, but also deep in here. Middle cerebral artery is actually going to come around here, and it's going to do this lateral portion. And then posterior cerebral artery is going to come around here and do part of your occipital region. So again, frontal is more midline and anterior, and then this. So you can have just this, you can have just this, you can have just this. And those are going to be some of the more common patterns because those are the three major blood vessels that supply the brain. And there's going to be some variability with this circle of Willis too. I've seen posterior communicating arteries that were no larger than a capillary bed, and I've seen posterior communicating arteries that are very large, like pipelines. So your ability to survive a stroke is going to be in part like where did the clot happen in this structure, and then was there an alternate route based on the size of that circle or the thickness of the blood vessels in that circle. So when somebody's had an ischemic stroke, we're going to try to, I love this phrase, salvage the penumbra. Time is tissue, right? Our goal here is to maintain the vasculature, maintain blood flow without having that long period of hypoxia so that you don't get that reperfusion injury. And I kind of mentioned TIAs. Our neurologic symptoms of TIAs should only last a few minutes. They should resolve completely with no evidence of neurologic dysfunction. And they are warning signs. If you've had one TIA, you might have another TIA, you might go straight to stroke. There's a very, very high risk of a subsequent stroke. So if somebody has had a TIA, they can do some preventative things like daily aspirin to thin their blood and make it less likely that they develop clots. Yeah, absolutely. If you're taking blood thinners, you are more at a higher risk for hemorrhage anywhere. Any hemorrhage. Where is that? Endarterectomy. Carotid endarterectomy. So doing something to those carotid arteries. Yeah. Yep. And of course, hemorrhagic stroke could be related to severe chronic hypertension. Physically, a lot of them are going to occur in the basal ganglia or thalamus, so midline structures, deep brain structures. And because we've got our secondary injury, because this is blood-based and not a blockage, that just simply leads to, you've got both the introduction of blood and the ischemia happening simultaneously, mortality is much higher with hemorrhagic. So we stabilize the cardiovascular system. We do a CT because this is an emergency. We monitor ICP. And we're going to manage their blood pressure. We may actually keep them mildly hypertensive just to try to keep blood in so we don't have reperfusion. After a cerebrovascular event, there can be any number of stroke sequelae, and like I said, it's going to be based on what part of the brain. So motor deficits, if it's a motor region, sensory deficits, if it's a sensory region. You learned your pathways, your spinothalamic, your enterolateral pathway, your DCML, and how you can have different types of sensory pathway if it was, say, in a certain spot in your brainstem, for example. One thing that could happen, especially with that middle cerebral artery, which remember is doing this entire lateral portion of the brain right here, right, is linguistic deficits. So Wernicke's and Broca's, left or right hemisphere? Wernicke's and Broca's, are they on the left hemisphere or right hemisphere? Left hemisphere only. So if you have a left middle cerebral artery infarct, it is very likely that your stroke sequela will include language deficits. What did Wernicke's do? The understanding of language, absolutely. Language comprehension. What did Broca's do? Production of speech, excellent. I'm glad you guys came up with that right away. So you could have an infarct to Wernicke's area where you would be still capable of producing speech, but it might not make sense. Or you can have an infarct just of Broca's where you can understand things and you know what you want to say, but you can't physically say them anymore.
Is that kind of like with locked-in syndrome? Where you
A little bit. Locked-in is just motor.
Oh.
What's up? Expressive dysphasias, yes. Or you could have an infarct anywhere along this pathway and have some combination of the two. So I'm going to stop this because we're going to watch a video of my favorite person with Wernicke's aphasia. His name is Brian, and he's beautiful. What we got from that video, and I don't know if you noticed, they were calling him Byron, but his name tag said Brian. Did anybody else notice that?
I didn't see that.
That's always bothered me. It's like, is he Brian or Byron? Did they just have a typo on his name tag and nobody cares? But what we're seeing here, and again from student reactions to this, is that it can be very, very severe where the words have no relationship whatsoever to what's happening in front of that person, or it can be the opposite and there can be some connection. It's like they're accessing neurons that are close by, but not quite the ones that they need. Right, their circuitry, it would be a smaller injury, right, if you can still access nearby neurons, if you can still access nearby circuits.
Is Broca also when they do not even words, it's like they're
With
and
Broca's,
you know exactly what they're saying.
Yeah, with Broca's, they wouldn't be able to form speech. They wouldn't be able to go, A-E-I-O-U, I am trying to say words, right? They could think that. They could say, I know exactly what I want to say. Depending on the pathway, they might be able to write, but again, because it is a different part of your brain responsible for reading and writing and speaking, and that's all different. But it's close by, so you never know. Maybe you would rather have Wernicke's just so you can be adorable. Yeah, like he has an idea what he wants to say. It's clear, but he can't process the language to say it. Yeah, it's language processing. Maybe, maybe not. I mean, he's probably been informed multiple times that he's not producing the correct words. It probably sounds correct to him. Because again, the same Wernicke's that's processing what he wants to say is processing what he hears.
Yeah. They think that they're just having a full conversation with you.
Mm-hmm.
And they have like
Yeah.
expressions and they laugh with you.
Yeah. And you would anticipate a lot of frustration, which is part of why I appreciate Brian so much. Is that like he's got a really good attitude about it. He's just like, I hope the world lasts for you. Like, I hope the world lasts for you too, Brian. Or Byron, whatever it is. Okie dokie. So again, you cannot get those neurons back. Brain plasticity is a function of age and biological sex. It is actually fairly well understood at this point that men's brains are plastic for longer than women's brains are. So if you're a 25-year-old woman and you got on the back of a motorcycle of a 25-year-old man and you both crash, he's a lot more likely to recover than you are, which is kind of unfair. So yeah, because women's brains lose plasticity a lot earlier. So if you are able to go to rehab and relearn some of these skills, it could be a mechanism of several things: new brain regions compensating, existence of stem cells, that's going to contribute to brain plasticity. If you have stem cells available, very, very specific brain regions can have mitosis of neurons, but very, very few. That's the exception to the rule and should not be counted on for brain rehabilitation. So where there is rehab, sometimes we have these miracles where people are able to walk again after all of these accidents, even late age. But the mechanisms for that, it's sort of few and far between, right? We don't have the healing of the axons. We don't have mitosis of the neurons. What we would have is maybe astrocytes helping, you would have other cells helping, you would have compensation. Yeah. Well, it's a really good region of research for stem cells is in brain rehabilitation. Yeah. What's that? You've donated stem cells? Nice. Nicely done. Yeah, stem cells are such a great avenue for research. But obviously there's ethical issues with some of the old ways that we used to gather stem cells, and we've had to spend 20 years developing science to get stem cells in more ethical ways so that we can do the research on stem cells to start healing these things. Yeah. Depending on your personal ethics. We're not going to have that debate. Let's see. So cerebral aneurysms. There's a lot of cultural misunderstanding about what aneurysms are. The aneurysm is itself, as you know from our blood vessels lecture, is that it's just an outpouching. So it's going to be a thinned portion of blood vessel. It's especially going to be there in the case of hypertension. Somebody who already has hypertension that's chronic is going to weaken the blood vessel walls, and then that may cause something that bulges out. We're coming back to this idea of aneurysm within the cerebrum because, again, this is a very limited space. So usually when you have an aneurysm somewhere else, you may or may not know about it. It's a ticking time bomb. It could hemorrhage at any moment. It's serious. In your brain, the aneurysm itself can impinge parts of your brain and cause neurologic symptoms before it bursts. And then if it bursts, you're going to end up with one of your hematomas, depending on the location of that aneurysm. So obviously a hemorrhagic stroke is a very, very bad thing that we want to prevent. And also those neurologic problems, those cognitive things that happen when something's pressing on your brain can also be quite difficult. Congenital defects of the arteries, so connective tissue disorders would also make this more likely. I think that's all I care about there. Arteriovenous malformation, or AVM. This is going to be, I think, mostly congenital, as I understand it. This isn't something that develops later. Your normal capillary bed, you'll have the arterial end, you'll have your capillaries, you'll have your venous end. Maybe you'll have a thoroughfare channel where things can bypass if this capillary bed is kind of cut off. But in an AVM, this capillary bed is poorly formed. It is really weird. So what's one of the things that happens to, let's say, blood pressure? How does blood pressure change across this healthy capillary bed? It should decrease. We should have a decrease of blood pressure across this. Now let's say your artery goes straight to your vein, or your arterial goes straight to your venule. Your blood pressure doesn't go down. Now you're in this thin-walled vein with really high blood pressure. So it's going to be fragile and prone to bleeding. So that could lead to aneurysm. It could lead to hemorrhagic stroke. Even before that, people I've met with this were prone to seizures and neurologic dysfunction. We will talk about seizures. Why they happen is poorly understood. All a seizure is runaway synchronicity of neurons. The neurons are all firing together when they should not be. They didn't receive a signal from a normal pathway that says fire. They all just fire. Everybody fires. So somebody with an AVM may be developing seizures or have seizures already. Yes? No, it would be in specific spots. So somewhere, not on this computer, unfortunately. I used to work with a guy at Metro who had recently been diagnosed with an AVM, and he gave me a CTA DICOM stack, and you can see his little frontal lobe AVM that he has. Yeah, it would be in specific locations. There would be monitoring for him. He was ultimately cleared to do his regular activities. They're like, yeah, you can go skiing. Obviously, if he goes skiing and hits his head, he's going to be in much more danger than a normal person going skiing and hitting their head. Yeah, safety, blood pressure. It's good thinking. I'm sure there's more that you could do. If it was determined to be very serious, there's surgery. There's things that we could do to switch that. I would imagine so, but again, I don't know necessarily. What's up?
Would someone like this have to take union or lasix to try to regulate their absorption at the periphery?
Again, I would ask the clinicians what we do for this in terms of blood pressure control. I imagine, yeah, treating your blood pressure. If there's high blood pressure, again, this would be dangerous even with very normal high blood pressure. So at a certain point, you're going to have really low blood pressure with that management. Yeah. Then you've got your orthostatic hypotension. And then you fall over and you burst your AVM.
Do you know what caused him to look for it? Like, was he having symptoms?
I think he was having seizures.
Okay.
Yeah.
Cool. Well, not cool.
I know, not cool, but he caught it, which is the important thing. And his was minor enough that he got cleared. So it's good stuff. Let's see. So CNS infections, they shouldn't be as common, right? Because you have a blood-brain barrier, so it's less likely that viruses and bacteria are going to make it into the brain tissue itself. It doesn't mean they don't exist. More commonly, the meninges will get infected because that's beyond that blood-brain barrier. So meningitis, especially in people who are immunocompromised, or are otherwise vulnerable, poor nutrition, radiation therapy, steroid therapy, or other contact with vectors. You may have heard for meningitis. Do you guys have to get vaccinated for meningitis? Yes, you do have to. Everybody's, no? Yeah. Right, they usually have that recommendation. If you're in a tightly packed place, if you're in college, if you're in a prison population, which is really similar for disease vectors, then you should get that meningitis vaccination because that gives you more exposure to the vectors. Yes?
So when you get the meningitis, would it help at all with, because I know meningitis is passing at the blood barrier going into your spine. Does that just help you become like the cell being there being more like stronger?
So I believe that vaccination, I'm not sure how that I keep saying hepatitis, I think because we were talking about hepatitis. Meningitis vaccine, because there's the bacterial form and the viral form, right? I don't know if it impacts the bacterial or viral form more, so I don't know the exact mechanism. It's the bacterial form. I don't know exactly what the mechanism is if it's bacterial. We can, again, search for that as well. So again, it's most likely to be strep or strep. And again, we're worried about accumulation of inflammatory exudate. If that makes it into the ventricles, remember our ventricular circulation, our CSF circulation, goes through some tight spots. Those interventricular foramina, that cerebral aqueduct, those median and lateral apertures, right? Those guys, they're small. So if you get something bulky in that space, you can literally block that CSF circulation and develop hydrocephalus as a result of that. And we will talk about hydrocephalus separately. So meningitis, yeah, that's really bad. Meningitis presenting with headache, fever, stiff neck, and signs of cerebral dysfunction, including confusion and delirium. Diagnosis with a lumbar puncture, and if it's bacterial, we can do IV antibiotics. As I understand it, the bacterial form's the more serious form. The viral, yeah. That's the one where if one of you gets bacterial meningitis, you have to tell everybody, and we have to get everybody cleared. Yeah. So if you haven't gotten vaccinated for this, go get vaccinated. Between colleges and hospitals that you're going to be exposed to, it's a vaccination. Go get it. Let's finish encephalitis and then go on our next break. So directly within the brain would be encephalitis, inflammation of the brain, usually as a result of West Nile virus, Western equine encephalitis, or herpes simplex virus in some cases. So again, if it's something like herpes simplex, it's probably immunocompromised to start with. And that's, again, it's going to be pretty severe if that occurs. We want to address that as quickly as possible. That's about it. Any questions about this before I stop for the hour?